Hello, everyone, and welcome to this audio podcast. This is the Shientist, and this is an audio podcast, a Storm Ballistix production in line with RPSG and KDOS Collaborative. This is part of the Ballistix edition, and it's the Loci Equinox. This is an audio podcast in and around proteinuria. So proteinuria is where there's the presence of variable or persistent amounts of protein in urine, or identifiable protein in urine, or through urinalysis, and where there's a sign of renal insufficiency or leading to kidney damage or renal damage. Proteinuria and estimated glomerular filtration rate are also sort of a basis for CKD or CKD evaluation. Proteinuria can help identify patients who are suspect or high risk of progressive renal damage and increased sort of morbidity. The presence of protein or proteinuria through urinalysis is generally an indicator that a recipient has a high probability to experience renal insufficiency or renal decline. The association of proteinuria and estimated glomerular filtration rate can also help in the prediction in context of capacity capacity and extent of renal damage as well. And proteinuria is a marker and can be sort of used as an independent marker or biomarker aligned to sort of other risk factors. In context of protein physiology, then the glomerulus produces primarily urine or urine by filtering blood, and retains a sort of larger proteins, including serum albumin. And serum albumin is known to be one of the largest proteins. One of the largest proteins in general physiology, and proteins with a molecular weight below 60 kilodaltons pass freely through the glomerular basement membrane and are actively reabsorbed within the renal tube and through renal tubules and the tubular systems. The renal tubules reabsorb proteins, and some of the albumin can pass freely through the glomerulus. Around 40 to 80 milligrams of proteins can be excreted per day, but 30 to 40% of that which is excreted tends to be sort of a minutia in related to albumin. Universal value for proteinuria generally does not exist. Other factors such as the kind of the sort of specimen or urine specimen and age tends to be a consideration in regards to renal damage. So proteinuria also is a sort of a terminology linked to where there's where in regards to a more definitive form of protein or protein leaking can be albumin or albuminuria, and a urinary albumin excretion rate of less than 30 milligrams per day is considered as normal. Albuminuria is defined as the elimination of urinary albumin excretion above 30 milligrams per 24 hours. And urinary albumin excretion is a continuous variable, and the lower values, the lower the value, the better in context your urinary albumin excretion. In the case of sort of levels higher than 300 milligrams 300 milligrams per gram, or 300 milligrams per day, that the term is then referred to as proteinuria. Albuminuria is a sensitive biomarker or marker for the detection of and in and around where recipients may be suspect or at high risk for specific forms of chronic kidney disease or CKD, for example, where there can be IgA nephropathy. It can be FS, GS, or focal segmental glomerulosclerosis, and also where there can be for example, other forms of nephropathy. In regards to the sort of proteinuria and classification, urine protein concentration can be a result of different sort of mechanisms involved as far as renal physiology is concerned. And in this overview, there's pre-renal, glomerular, tubular, and post-renal and orthostatic bases for the types of proteinuria that can exist, and aligned to that, there is a characterization. For example, with pre-renal, the proteinuria can be a basis as a result of overproduction an overproduction as a basis of characterization related to pre-renal cause of proteinuria, and observed in hemoglobinuria, rhabdomyolysis, monocytic leukemia, and myeloma. Are also a basis of characterization of why there could be pre-renal causes of proteinuria for urine where urine concentration has or is affected due to protein leaking. In this sort of slide or overview, there's an overview regarding sort of proteinuria and the diagnostics in and around that. So, on the as a first base principle, there's sort of screening methodologies, and then there's the sort of around sort of point of care. There's the quantitative methodology around detection, and then historically there has been a use of 24-hour urine collections, and in and around these sort of three or initial sort of phases, there are then or can be sort of additional phases where, for example, a mixture of dipstick screening modalities, and then sort of additional quantitative methodologies to detect protein in urea, and also for example, albumin or albuminuria as well. Here is perhaps a sort of a good depiction of what a 24-hour urine collection may look like. So generally can be inconvenient. It can be inconvenient for patients, and at the same time, can help identify sort of variable amounts of protein in urine in a given over a sort of given duration, and it's generally helpful in specific sort of diagnoses or parts of diagnoses, particular in recipients with tubular proteinuria, or where there's follow-up of patients with specific glomerular diseases as well, and generally from a laboratory pathology, or even sort of biochemistry perspective, 24-hour urine collections are not as sort of viable as they once used to be in context of analyses, but in specific populations, it can still be helpful, useful in specific forms of renal damage. Aligned to this, then, there's also screening methods around proteinuria. There's sort of there's the dipstick for screening of proteins, and dipstick screening for albumin, and in this overview, there's a sort of a description really of different sort of aspects, the different aspects that that screening allow in context of protein and albumin, and and these can be done. These can be done through a laboratory and through pathology, but also through sort of point of care sort of modalities as well. In relating to this, there are again quantitative modalities to measure protein, and then there's quantitative methodologies to detect albumin or albuminuria. Around protein, the protein quantification in urine generally can have variability in those in suspect recipients, and the most used modality around this is a turbidometric or benzothymine method or methodology, or at least historically has been, and around albumin or albuminuria, the most usual method or modality is through immunoturbidometry and nephelometry, and also high performance liquid chromatography or high liquid chronography can also help detect sort of non-immunoreactive albumin. Around PCR or so protein creatinine ratio and or albumin creatinine ratio, the KDOQI excuse me, guidelines recommend that urinary albumin creatinine ratio or ACR is used as a basis for diagnosis as a basis for diagnosis. And when the albumin creatinine ratio is high, so anything above 500 milligrams per gram, it can increase the removal of other proteins than other proteins than albumin in urine, so can help identify specifically tubular proteinuria. There has been some additional guidelines in literature known as the parade guidelines, which recommend the implementation of protein or creatinine ratio in pediatrics and young people. The kidney disease, specific kidney disease or renal disease, is often associated with abnormal urinary tract or tubular defects, which are characterized by elimination of small proteins. Albumin creatinine ratio is also recommended in diagnosis of other sort of specific glomerular diseases as well. Protein creatinine ratio is also used in tubular interstitial diseases as well. Really, in relating to proteinuria and CKD, chronic kidney disease progression, the presence of proteinuria is generally an indicator that recipients have a high probability of renal disease progression, even with even with sort of normal, or what would be deemed as normal glomerular filtration rate, or GFR. The progression and the risk of terminal renal disease is correlated with the degree of proteinuria, and the proteinuria is sort of a modifiable factor. The more it is reduced, the better protection for the recipient from renal disease progression and development of end-stage renal disease. So, in regard to the evaluation around protein creatinine ratio and or albumin creatinine ratio, the presence of proteinuria generally helps identify a group of population or a suspect or high risk for CKD. In CKD patients, the suspect in CKD recipients who are suspect or high risk, the albumin or protein excretion in the urine may be or is or can be a disease predictable. Albumin creatinine ratio may be obtained to detect presence of non-glomerular proteinuria. A value of albumin creatinine more than 2.5 grams per millimoles in males, more than 3.5 milligrams per millimoles in females, or protein creatinine more than 22.6 milligrams per millimole are indication of proteinuria. First morning urine generally is adequate for detection owing to the less biological variability and sort of good correlation with 24-hour albumin protein excretion. The mechanisms for proteinuria and progression in CKD are thus: so proteinuria can accelerate renal damage, and the process occurs through multiple pathways, or can occur through multiple pathways, including induction of tubular chemokine expression and complement activation that lead to inflammatory cell infiltration. Glomerular sclerosis is a progressive lesion beginning at the glomerular capillary wall and the site of abnormal filtration of plasma proteins. Albuminuria or proteinuria results from defects in the glomerular filtration barrier. So there's a compromise or sort of a damage effect around, for example, nephrons and around the podocytes, and the glomerular regions, a region around renal anatomy and renal pathophysiology. And overload proteinuria appears as a consequence of increased glomerular permeability, enabling glomerular passage of proteins. In line with sort of treatment, then the use of angiotensin converting enzyme inhibitors, angiotensin 2 receptor blockers, and aldosterone antagonists and renin inhibitors in recipients with proteinuria and CKD in literature has shown some advantages on the progression in and around prevention of prevention of CKD. The reduction of proteinuria with drugs such as ACE inhibitors or ARBs that sort of inhibit or block the renin-angioaldosterone system is associated with long-term sort of renal function protection in at least where CKD or end-stage renal disease ESRD is at the same time being sort of prevented as well. And due to risk factors, some recipients present response to specific therapeutic agents, and diuretic therapy have been known to be effective in improving the sort of anti-proteinuric action of the inhibition of the in and around the renin-angioaldosterone system, and in reducing or in around reduction of proteinuria. And evidence also highlights that aliskiren, a renin inhibitor, can also help reduce albuminuria as well. Acknowledgement to a few colleagues, collaborators who took the time to get involved in developing this sort of overview. Once again, this has been a Storm Ballistix production in line with an RPSG and KDOS collaborative, and this has been an audio podcast around proteinuria in and around the SZ loci, Equinox, and this has been an audio podcast as part of the Ballistix edition. Thank you.